Well, ladies and gentlemen, I wanted to come with something different from what I was using to say. And I would like to show you that, in fact, sustainable investment is the key for medical care. And not only that, but also ICT is highly important there. So the subtitle would be Investing to Overcome the Global Impact of Chronic Respiratory Diseases. Well, I would like to give 5 points. First of all, the lessons of the European Innovation Partnership on active and healthy aging. Secondly, the impact of the Obamacare in ICT. Thirdly, ICT and rhinitis, what we're doing with masks, and back to the partnership. So let's go to the lessons of the EIP. Well, the problem in Europe, which is the problem in the world, by the way, is that, in fact, the population is aging. And it is a problem for chronic conditions, for healthcare workforce, for financial unsustainability, and for health inequalities. So clearly, it's because we are aging that we probably will have major problems in the future, in particular for sustainability of financial things. And the European Innovation Partnership on Active and Healthy Aging was initiated 4 years ago. It includes now 74 reference sites across Europe, and there are over 850 commitments for action. So it is a very huge partnership. The major strength of this partnership, it is that there is no budget. So you need to be creative to find the money. You need to do what you want, but to make it clear. For example, in Montpellier, we have a false prevention initiative. We have an initiative from the National Pension Fund, which is bringing a lot of money, and we have also an initiative on chronic respiratory diseases. So what is this partnership? First of all, prescription and treatment adherence. Well, when you are over 65, you have a long list of medication, and it's quite difficult. The second is preventing falls. The third one is the functional decline and frailty. Then integrated for chronic diseases, and in this group I am leading the chronic disease pathway, and then ICT for independent living and age-friendly environments. However, I was surprised because the goals of this partnership are possibly to improve health and quality of life, but mainly to ensuring health and social care are sustainable and efficient in the long term, and to enhance the competitiveness of the EU industry through business and expansion in new markets. So, the EU did this program, which is a very large one, just to make money. Make it simple. They don't care about the health of the old age people, but they want to make money. And that's normal. At the first time I was very surprised, and then I said, well, why not? And then now I'm fully convinced. So chronic respiratory diseases account for over 1 billion people, and they are the model of chronic disease of the EIP. So that's quite good because we are recognized at the political level. And one thing which impressed the most the EU was that chronic respiratory disease starts very early in life, not after 65. And then they understood that it was also important to do it across the life cycle. Now, Obamacare. Well, I'm not Mr. Trump, I'm sorry. I'm not Mr. Trump. But he likes it at the end of the day, because he says, well, no way before the election, and now why not? Well, I tell you, the Obamacare, when you read it, is a phenomenal and extremely good proposal. The problem, it is that its application has been horrible. But look, the law put in place comprehensive insurance reforms that put consumers back in charge of their health care. If you say that, that's absolutely essential. And I think that patients' organizations should be very happy at that. And then, under the law, a new patient Bill of Rights gives the American people the stability and flexibility they need to make informed choices about their health. So when you see this, I think it is really excellent. And if you read what is the Affordable Care Act, it is really very good. Free preventive care, treatment for seniors, protect against healthcare fraud, small business tax credit, and so on. But probably the most important aspect of the Obamacare is investment in ICT. And after the Obamacare, and this was a quote from Forbes, so you know, something totally different. In this case, it was very clear that the Obamacare has induced tremendously the growth of ICT. So it is Forbes investment, ICT, care and the patient at the center of the system. I think that this is extremely interesting, and this is why I'm working for my patients. Now, if you go to another report, which is another business report, it is clear that we're facing an industry transformation and a seismic shift in business model. 20 years ago, or 100 years ago, the people ruling the drug industry were the chemists, then the pharmacologists, then the bankers, and now it is something which we don't know. And we don't know exactly where we go, but clearly ICT is important, and this will probably transform the healthcare industry. So ICT is first of all for sustainable investment, but also to transform the way the industry is going to work, but the way we're going to see the patients. And it's clear that the pharmaceutical industry is in the midst of fundamental changes brought on by increasing concern over the expiry of patents. Well, this is not mine, this is research. Weak product pipelines. Well, many products now come from very small startups and competition from generics. However, if we propose a global approach, not only a drug-targeted approach, a global approach, then the industry can make a lot of money, and making a lot of money can help us, because we should remember that without the industry, our lifespan will be 40 years. So now, ICT and rhinitis. Is Peter here? Oh, I'm sorry he's not here because I brought a car for him. Well, you have a 40 here, and you have a Rolls-Royce Silver Ghost. But you know the name of this car? Roi des Belges. I'm not joking. This is Roi des Belges, Rolls-Royce Silver Ghost. So, I think that we have two business models today. And the business models were the challenge of the car makers in 1905. Very few people could afford a Rolls-Royce, very high quality, very expensive, cost-effective for the very, very, very few rich people, very low numbers, and people paid cash. If you go to the 40 level, it's high quality, it is cheap, it is cost-effective for all, very high numbers, and it's paid in cash and by loan. So it was already a different economic model. Well, how can this translate to healthcare and rhinitis? Very simply. If you go to the challenge of healthcare in this century, you have rare genetic diseases in dozens, you have cancer in thousands, you have asthma in 100,000, and you have rhinitis in millions. So you cannot afford to give the same treatment to all these people. And it's clear that this is the Rolls-Royce approach, this is the BMW approach, this is the Ford T approach. However, is this approach going to be sustainable in the future? Because we have the Tesla approach, and this is transforming everything we think. And even BMW was able to go the next 100 years with an electric car. So I think that we need to rethink the way we're practicing medicine in a way where ICT and electronics will be of extreme interest. Now, what can we use? Well, there is the electronic patient medical record, which is a major advance, but it did not bring us new things or new thoughts. So it was just helping us to better practice medicine. Then you have this, you have the pollen counts, and this is the best system. It is in Vienna. You can predict more or less the pollen counts sooner or later. But still, if you want to do the 24 hours of Le Mans, you're not going to take a 1910 car. You would prefer to take a 2019 car. So we need to do something else. And my good friend Mosgus, Ralph, did this very interesting study. He assessed the Google trends. So what are the trends in rhinitis? And how can we relate these trends to pollen counts? And in fact, they do. So instead of doing pollen counts, it might be much better to assess Google and to predict and to do a digital evaluation for a sentinel network. And in fact, this is clear, it works. Many studies have been done since then. So we are already in the transformation of what we knew to what is the novelty. And finally, you have also compliance to treatment. I'm not sure that it works very well, but it is something we may envisage. So now I would like to go to my baby, which is MASK. It is Magvia Area Sentinel Network for Allergic Rhinitis, and the term was coined by Ruth Murray, who is in the room. Well, what it is. I am fed up of guidelines, and I will tell you why tomorrow, because I've been working for that for 20 years, or 30, and now I think that we need something totally different. We need a new generation guideline implementation. And this is what we're doing, in particular with Mike Buick, who is going to speak later. So first of all, we need a common language to control allergic rhinitis. For this, we need three things, and that's it. First of all, a smartphone. Secondly, a line. Thirdly, a finger. With that, you can control any disease in the world. I'm not joking. You have a cell phone, a clinical decision support system, I will discuss that tomorrow, and your finger. And that's it. Everything is computerized. So I think that we are moving towards something different. Well, we need to have care pathways. And with Mike, we are dreaming to use a similar care pathway for all chronic diseases. Because one of the problems of the health system today is that we go towards acute medicine or severe disease. But the bulk of patients is rhinitis. The bulk of patients is mild people. So, and there is nothing there. So we need to have care pathways from the patient, because the patient is self-medicating, accessing computers and everything you want, to the pharmacist. In many countries, pharmacists are seeing most of the rhinitis people, to the primary care physician, to the specialist. And for this, you need a single system, and we have developed it. There is a tablet, which will be available by the end of the year, and there is a cell phone, and I can already show you some data. And for this, it's very simple. The patient, a visual analog scale, a clinical decision support system, and a cell phone. The pharmacist, the same, and a tablet. And the physician, the same, and a tablet and a cell phone. So with that, it's enough. So we are making simplification, and we can do that for any other chronic disease. Well, our mask, it is free in Apple Store and Android. It's now in 20 countries, 15 languages. It provides a common, simple language for patients and healthcare professionals. It is a simple and effective tool for precision medicine, because we can go to precision medicine with this. It stratifies rapidly uncontrolled patients despite optimal treatment, and reduces probably from first symptoms to allergy immunotherapy. And the same tool can be used to stratify patients to be enrolled in clinical trials, to perform clinical trials, to study efficacy in interventions in real life, and to study the persistence of the effect when an intervention is stopped. It can be used in the elderly, and it is a tool for healthy work in rhinitis sufferers, and this will be the next two presentations. Well, first of all, we got around 2 million euros from a drug company, but they donated the tool to the region of Languedoc-Roussillon. So it is a tool which belongs to a region in France. And it is both MAGVIA, so it is our against fighting chronic disease for active and healthy aging, the region tool, and ARIA. So it is very simple. Well, we've spent a lot of money in terms of reference and use because this has been customized by lawyers for each individual country we are. So if you're in the UK, you can download the app, but if you're in Ireland, you cannot because we're not in Ireland yet. Well, we also got money from the EU, from the European Regional Development Fund. So it is a dual EU project. First of all, MAGVIA, which is reference to the EU, and EU funds. Well, this is the simplest thing you can say. You tick one or several of these 6 symptoms, and you tick affect my sleep, restrict my daily activities, restrict my participation in school or work, and are troublesome. Do you think that this can make a paper? The answer is yes, because we used something new, and I learned something in rhinitis. So not only it is a modern approach, but I learned new things. Well, very simple. According to the medical expertise, I said, well, it's better to say the number of symptoms instead of mixing them. Well, I'm not sure that anyone in the room has tried to assess numbers of symptoms. And here it's simple. You have nasal symptoms, yes, no. You have rhinorrhea, yes, no. And if you have rhinorrhea, it's one, no symptom, 1 or 2, or the 3 and all. That's it. And it is, the database is on real-time database now. So we assessed 3,000, the first 3,000 users. And these are the results. They are quite impressive. You have no rhinitis, you have no impairment in activity in work or sleep. Well, it should be demonstrated with this tool. And then, if you have rhinorrhea with 0, 1 to 2 symptoms, 3 to 5 and all, you have an increase in the yellow bar, which is the activities. You have an increase in the brown bar, which is work, but you don't have an increase in sleep. So whether you have many symptoms or not, you have sleep. Why? Because nasal symptoms are more important for sleep than ocular symptoms. We showed that as well here, but I can't show you every data today. Now, with this visual analog scale, and you put your finger into the visual analog scale, we have one for overall, one for nasal symptoms, one for eye symptoms, and one for asthma. These are the results for 11,600 days. So you see that when people put their finger in their cell phone, they can put it again for other symptoms, because the correlation is 0.82 for 11,000 days. I think this is remarkable. And I can tell you something. I'm not going to show you that today, but we have data on 16,000 days of treatment. And we're able to differentiate loratadine versus cetirizine and Avamis versus Nasonex, and Dimista as well. So, and I can tell you something. None of the patients follow the guidelines. 0 or 2%. There are only 3 or 4 British people who are using the same treatment across their 20 days, and they have different symptoms. The others are using what they want. So it is not 2 to 4 weeks of treatment, it is half a day. If in half a day they don't have an improvement, they change that treatment. And this kind of system can tell you what you're doing. Of course, we have a control, and now we have a clinical decision support system. And this clinical decision support system has been, first of all, published in the JCI, Then we had a monkey survey with experts, and Ruth did that as well. And then we have done with the École des Mines d'Alès a totally, we have modelized this, and everything can be done with your finger, simply. So we have an urgent need to propose an innovative health system for one of the most common diseases globally. We need also to show that it costs possibly 50 billion euros a year to the community because of work, and the two next speakers are going to say that. Most patients can self-manage their symptoms, and we are going to that direction for all diseases. For rhinitis, we have the strength that people feel it. For hypertension, they don't know. And for diabetes, they need to measure their blood. Otherwise, for rhinitis, they can just do that with a cell phone. Most patients need OTC drugs at the pharmacist. And we discussed what was going on in Belgium, and I said to my friend here that I was thinking it was good. A few, but still in millions of subjects, need a medical advice. And fewer, but still in millions, will need a specialist advice. So our system is not to detract the patients from the doctors, but to select those patients who really need the doctor and the specialist. MASP provides a common language to all. The clinical decision support system will help patients to self-manage under the control of their physician. We have also EQ5D, because then we have an evaluation of the economic evaluation of the treatment. A warning on asthma is in place. And what we need now is to go further for reimbursement patterns and things like this. Now I would like to go back to the partnership on active and healthy aging at the European level. Well, first of all, it has been approved by the EU, and it is official at the EU level. So at least in respiratory medicine, we have something official. Secondly, it has been approved by WHO, and also, and you see that we have something like 450 people there. Anyone who wants to work with us, please call me or write me a mail. Well, Mike, you are the first to approve this, and this project was launched by Dr. Mike Buick, who was the Deputy Medical Director of NHS England at that time, and we did that in Newcastle. It was a wonderful time because I met this gentleman, and since then we became friends. We like to have good dinners together, and we are working together. It's wonderful. Well, the problem now is that 20% at least of rhinitis patients, of elderly patients are going to have rhinitis, like other disease. What is the phenotype? What are the treatment patterns? Are some treatments for rhinitis going to induce asthma? What? We don't know. So I convinced the EU to have a second program, and this has been recently accepted. It is called MASK Twinning. It is the transfer of innovation on allergic rhinitis in old age people. And it is, again, an EU project. So what we plan to do, we plan to work with the general objectives are to compare phenotypic characteristics of rhinitis in adults, in old age, and in adults, using the tool I showed you. So it will take every person who is going to enroll the patient 1 minute. Do you know many clinical trials with 1 minute? Second, to better understand, assess the burden, diagnose and manage rhinitis in old age. So we're going to have a cross-sectional study and a longitudinal study. Cross-sectional, physicians will enroll 15 patients. That's it. They will fill a questionnaire which will take 13 questions online, 1 minute. And then the patients will fill their questionnaire. And we hope to have 10 to 15,000 subjects at the end of the year. So there will be a longitudinal study when people are going to use the product long. So where are we? Well, it's moving every day. In black are the reference sites. We had 10 reference sites when we applied in September. We are now close to 20. For example, I met in Brussels the person of the region Born-Colne, and this person said, okay, I'm interested. So I met, well, I have a meeting here with Ralph Mosgus and Thomas Bieber, and we have already decided to do it, but Ludger Klimek said, well, with my society, the German society, we are going to expand to the entire Europe, to entire Germany. In France, it's again, we are going also to expand to the entire France with the French Association of Allergists. So what to expect is to have this project, which will be done across Europe. We're in Turkey, we are in Poland, so Portugal, Italy, Turkey, Poland, Germany, and France, it is the entire country. If any one of you wants to come to this project, please do, because the database is available, it is online, it is free access, and there is no cost. And the data are quite compelling, as I showed you. Well, ladies and gentlemen, who leads healthcare in Europe in 2016? There is a bright building and a dark building. Do you know what is the bright building? It is the EMA. Who will lead healthcare in Europe in 2020? Well, probably the bright building will become dark, and the dark building will become bright. Do you know what is the bright building now? It is the European Central Bank. I do think that approval of medications will still be done by EMA. But as it has been done for mepolizumab, IQUIC and NICE didn't like it because it is money. So what I'm proposing to you, it is that we need investment in healthcare, and this investment should go through ICT for sustainable investment. Thank you.